you so much for inviting me, and sorry for all the hassles on the presentation. But as Renu Madam also has said, I would like to start with the basics. First is anatomy of the uterus. Madam, all of us will agree that uterus is or the endometrial cavity is a virtual cavity. It has inadequate light transmission. It bleeds from the inside, and it has inability to distend. It has a myometrium which contracts and causes problems. So according to us, it's a virtual dynamic cavity, and therefore we require some light to be thrown in. We require fluid, which has already been spoken of, and I will not waste my time. I will just come to next important point, and that is the blood supply. One important point that one has to remember is from the we get the blood supply from the uterine and the ovarian. We have the arcuate vessels which are seen in the myometrium, and as they give branches, they go to the radial, and then from the radial in the basal there we have the basal vessels, and in the endometrium they branch out into the spiral. What is important is we all talk about the mean arterial pressure, but what one has to remember is there is something known as the venous pressure, and the venous pressure is just 15 mmHg. So there can be passive absorption of fluid from the venous venules also if the pressure is high. Then coming to the next point, and the distension media. So as already spoken of, I will not waste my time much, but we are done away with the gaseous or the CO2. We have only the fluid media, and that is required because the fluid media gives us symmetric distension, clears the blood and mucus. And you will all agree that the low viscosity, that is the electrolyte, normal saline is used as the distension media, and it's the preferred media because now we can use bipolar, which is much more safer, though those who are well versed with monopolar and glycine can still use it. But today is the era of bipolar, and bipolar goes with normal saline. Most important point that has to be covered, we should know when we are dealing with what you call the fluid media, is what is the osmolality. That plays an important role. And when we say osmolality, it is the concentration of osmotically active particles in the solution. So the question comes is, do we know the osmolality of the plasma? Well, the plasma is 285 m-osmoles per liter. And therefore, the osmolality of normal saline is about 285. So it matches the plasma. So it is known as isotonic. While glycine, sorbitol have much less osmolarity, that is glycine has 200 and sorbitol has 165, and therefore they are known as hypotonic solutions. That is, the salt content is less than what is in the plasma. So this is what is important for us. What is hypotonic solution and isotonic solution? Isotonic solution doesn't cause electrolyte imbalance, whilst hypotonic solutions causes the sodium to lower down, hyponatremia, and then causing complications. So what is the ideal fluid now? We should know what is sorbitol. Sorbitol is just a reduced form of dextrose, and it is metabolized by the kidney and excreted by the fructose pathway. Glycine is just an amino acid which has a half-life of 85 minutes. Mannitol is a sugar which is again an osmotically diuretic and isomer of sorbitol. But normal saline is electrolyte rich, no electrolyte imbalance. It goes with bipolar. And why normal saline is ideal for you? It is isotonic, it is non-toxic, hypoallergenic, non-hematolytic, hemolytic, rapidly cleared by the body, readily available, inexpensive. The vision is clear, and the most important thing, it has what is known as the peritoneal reabsorption process. So even if the normal saline accumulates in the peritoneal cavity, it can over a few days get reabsorbed into the system without causing problems. But is it still safe? No. No fluid is safe if used with high pressures and with use for a long procedure time. So it is already dealt with, but I'll just go with the methods of distension. The simplest way is the gravity fall method, which is like driving a cycle around the slope. As soon as the fluid in the bottle starts coming down, the pressure decreases. And one should know, this is very important, that the pressure delivered into the inflow port is a product of the inner diameter of the tube and the elevation. The higher the elevation and bigger the tube, more the pressure. But as the elevation starts decreasing, the pressure starts decreasing, and then it becomes difficult. So for prolonged method of this should is not possible. Okay, for diagnostic small biopsies, you can do it. To begin with, you can do. The second is the pressure bag. So here you have no precise control. You have a person who is pushing 180 mmHg on a sphygmomanometer, and it is like pushing a car to accelerate. So you have to go on pushing. It requires practical and it cannot be used for long procedures. So I always advocate, and this is not industry driven, mind you, this is safety driven, that we should use when you're doing long procedures, automated fluid systems, and this is AAGL guideline, and this is not my guideline. Basically, it will tell you a rough estimate of the intrauterine pressure. It will tell you the irrigation flow, 200 ml per minute or 100 ml per minute. It will tell you at what it is delivering pressure. It has a sensor, it has a pump there. You can purse the tubes entirely of air, which we were dealing with air embolism, and therefore you will have a non-pulsatile flow, and therefore it helps you in attaining some form of safety, and you can work at low pressures. What do you mean by low pressure? So pressure adequate to open up the uterine cavity and a good vision. And therefore, I always prefer to use endomats right from my beginning. Though it is slightly costly, I can definitely mind it, but it gives safety to you. Why is fluid management necessary? See, hysteroscopic vision requires distension of the uterus. There is inflow and outflow. I always go with the outflow open. So whatever goes in has to come out. So it requires continuous turnover. You have to remove the blood and the debris. And operative hysteroscopy requires large volume of fluid that can be absorbed, and therefore fluid management becomes a necessity. Well, internationally, if you see all the papers, they say the severe complications of fluid absorption is as low as 0.1 to 0.2, but as mentioned by Madam Jain also, it is seen that 1 in 2 to 3 patients land up with complications, and I always get phones also saying how we could have avoided this complication. So knowing safety principles is very important prior to starting any hysteroscopic procedure, though it appears very easy that you're just putting in a scope in. But the uterus is a dynamic cavity. It has a blood supply. It has a vessel. You have to know the mean arterial pressure. You should know the venous pressures. And what are the predisposing factors? This is very important while planning. You should know a hypotonic solution. You should know that there can be intravasation syndrome. In premenopausal status, the chances of fluid intravasation is more. Then patients with comorbidities, you will have a low mean arterial pressure. And therefore, these patients can be susceptible, even in a short procedure, to have problems. Secondly, which are the procedures that can cause or predispose to absorption? G1, G2 myoresections. Whenever you're going within the myometrium, you're going to open up vessels. Now here, you have to limit your dissection to the pseudocapsule. If you respect the pseudocapsules, the vessels are not open up. If you inadvertently open up the pseudocapsule, then the intravasation is more. In endometrial resection, you should be definitely very careful while opening up. You should immediately cauterize the vessel as soon as it opens up. In complete septum resection, it is a long drawn procedure where we all now know that septum is not just fibrous tissue but also muscular tissue. So high intrauterine pressures, low MAP, surgery time, large cavity more the surface area, and myometrial penetration. These are the 5 components which can predispose to fluid absorption. I had a beautiful chart I'm unable to share, but I will share it to you later on. And that is, it tells you very clearly that when blood vessels and sinuses are transected in deep myoma resections or endometrial resections, coupled with high pressure, we are unable to see, and the duration, this triad then leads to problems of fluid absorption. It's not that saline is absolutely safe. It can cause cardiovascular failure, it can cause CCF, and you require treatment. But with hypotonic solution, that is like glycine, what happens is glycine is known to cause dilutional hyponatremia. And what is hyponatremia? There is osmotic imbalance. That is, the sodium particles are delivered outside the cell, they cause reabsorption of fluid, they cause water into the brain cells, causing cerebral edema, and then you can have seizures. At the same time, glycine is metabolized in the liver and it gets into ammonia. Ammonia can cross the blood-brain barrier, causing agitation, vomiting, and coma. So you will have the neurological toxicity more with glycine, while with normal saline, you can get with the lesser evils, that is pulmonary edema, which can be managed. So we should know what are the safety limits of fluid absorption. So as Magos has said, or everyone says now, with glycine, it should be 1000 ml. That is intravasation, we should stop. In a comorbid with 750, you should stop. With normal saline, it goes up to 2500, and it has been proven that up to 1000 ml of fluid absorption can be tolerated well in normal saline. The first sign of hyponatremia can be at as low as 500 ml deficit. And what are the problems that creep up then is the calculation problem. As rightly discussed initially, how to calculate the fluid deficit is very difficult. So you should have a fluid management system in place in the OR. You should have a team proper. You should have a person who will always tell you what is the fluid, which is the bottle that is going in. One. Secondly, how much is the fluid being collected to or on the floor, which is mopping, and therefore knowing the fluid. So every 10 minutes we should be doing. But preoperatively, we should also do a sodium electrolyte baseline and then calculate every 10 minutes if your procedure is going to increase for a longer duration time. Second most important thing which everyone should know is we calculate the volume, but it should be weight-based volume that is more important. Difficult estimating the remnant volume in the bag, actual volume in the 3-liter bag. If you see in a Baxter's bag, it has been reported that it has about 6% more volume. That is, if you say it is 3 liters, it can be 3,101, 105, and therefore there is a miscalculation. Even the canisters which are used to calculate fluid, if they show 3-liter canisters, usually they are not calibrated properly and they are actually 2750 only. So you can have a miscalculation. Secondly, as Madam rightly pointed out, if the sudden blood vessel opens up, there's rapid absorption of fluid if there is high pressure, or if there is perforation, you can have sudden fast absorption and you have difficulty in calculation. So what happens is in the premenopausal patient, especially when you're using glycine, there is something in the blood-brain barrier known as the sodium-potassium pump, and this is inhibited by the estrogen progesterone. So if as a safety measure, you're doing a large myoma, maybe GnRH may not be able to reduce your myoma size, but it thins out the endometrium, allows less fluid to be absorbed in, and at the second time, it preempts or blocks this estrogen progesterone receptors on the sodium pump and allows sodium to be extruded out of the cerebral fluid, and therefore is preventing indirectly fluid absorption. And this has been proved by many papers. So GnRH, though may not reduce the size of the fibroid, but can help you in preventing complications if it is given preoperatively. And what is intravasation of hypotonic solution? This accumulation of free water, and this free water then causes or moves with the extra and intracellular spaces and causes intravasation, leading into the brain, causing cerebral edema, increase in intracranial pressure. And if the intracranial pressure or the swelling increases beyond 5%, you have cerebral herniation and then a death, imminent death. So we should be using certain drugs so as to prevent this. One is GnRH, and secondly, which I use in my practice, is whenever I'm dealing with a bigger case, I give intracervical diluted vasopressin, that is 5 units per 0.5 international units per ml, that is 5 units in 100 ml of normal saline, 10 cc at 4 o'clock and 10 cc at 8 o'clock, and wait for 10 minutes before I start the procedure. What helps is it vasoconstricts the vessels, leading, as the vasoconstriction takes place, the fluid absorption is decreased, and this has helped me in my practice eminently. Just going historically to the stages of hyponatremia, you have mild, moderate, and severe, and this can be dealt with that the normal levels should be known to you of sodium. Mild is at 130, 135, irritability, twitching can take place. Moderate is about 125, 130, signs of impending pulmonary edema and parotid sign comes positive, and severe is when it comes down to 120, 125 with hypotension, bradycardia, cyanosis. And below 120, it can give to convulsions. What is important one has to remember is that the first sign, if you are under spinal anesthesia, the patient coughs. The anesthetist should be alert. Secondly, if you open the eyelid of a patient under general anesthesia, and if you find a fluid cover over the eyelid, that is the first sign, even before the parotid sign, that the patient is absorbing fluid. And it is the best time you can give Lasix to prevent pulmonary edema, even in normal saline cases. What is the fluid monitoring system now? There are two ways of doing it. Previously, everyone did the manual way. That is, you have a person appointed who will calculate what is in the drapes. Now, if you use the PPH drips, you have fluid drips as used for delivery to calculate the blood loss. The same can be used. The fluid gets collected in the pouch. You apply a suction tube to that and connect it to the canister. The fluid gets connected without spillage into the canister, and you can then calculate the fluid properly. That is one way. You have to mop the floor also and collect, but this can have a 10% error, and the 10% error can be about 600 to 1500 ml depending upon the procedure. So what is recommended by AHL is an automated machine, a fluid management system. And if you see, there are few fluid management systems available. They are very costly. They give you a beep when you cross certain limits, and they will tell you exactly. And these are not volume based, these are weight based. So when you hang a 3-liter bottle, it weighs the bottle, converts it to volume, and displays the volume, and therefore gives you alarms accordingly, and it will beep as soon as you start going above that alarm. And this has been proven by a very good paper by Ilyas, wherein weight-based fluid management system adds more safety, and now it has been a mandate by the AHL that one should use the weight-based automated systems of fluid management if you're doing prolonged cases. You should have a dedicated person. Every 10 minutes, he should be able to tell you what is exactly happening. After each bag, an electrolyte estimation has to be done, and one should know in vivo, in situ, how much fluid is. Not, as madam said, that we cannot do it after the procedure, but during the procedure. There are many people on a safety side. This is absolutely random way of thinking, but they do it in a very different way, that after each 3-liter bottle, they ask you to give 10 milligrams of Lasix. Now, this is very arbitrary, but you have to follow a dedicated system to prevent complications, because hysteroscopy, as rightly said by all the learned faculty here, is that it's a small procedure, but it is a very tricky procedure, and it's a tricky procedure, and therefore one has to learn all the arts of preventing complications. Another thing is, does anesthesia affect absorption? And if you see, if you are giving local or paracervical, the absorption is least. If you are giving general anesthesia, the absorption is slightly more than the paracervical. But in spinal anesthesia, the chances, this is again proven by a paper, an RC done by Bergon Amy, who did this article, and therefore 90% of my procedures are in office. 10% which I do is under short GA procedures. But here, as a preventive mode, I always talk to my anesthetist what type of procedure I'm going to do, what is the time taken approximately. So he's vigilant, he's monitoring the screen properly and helps me. Is there any way to prevent any complication of absorption? Yes. Preoperative assessment of the patient, knowing the comorbidities, the age of the patient, hypertension, diabetes is very important. How the size of the myoma, the size of the cavity. You can give GnRH agonist, you can give vasopressin. But what is the commonest thing that we can do is the anesthetist, when they are giving anesthesia, they preload the patient. Ask them not to preload. So fluid restriction helps in preventing initial fluid overload, which is already in the body. Intraoperatively, you have to maintain just adequate amount of intrauterine pressure to able to see. And at the first instance, if you are seeing that the procedure is getting prolonged, especially this is a BSGE, British Gynec Society guideline, If it is going about 60 minutes, then stop the procedure, evaluate yourself before redoing or do a second step procedure. It has been proven by a very good Indian paper by Alka Kumar that temporarily stopping the procedure for 10 minutes decreases the rate of absorption, allowing intravascular clotting to happen, and then you can recontinue the procedure and achieve good success. This is a paper, a meta-analysis, which has been done for systemic review by Jade et al., and it shows that GnRH agonist and danazol are found to be effective in reducing fluid absorption. And there were 4 papers which also favored vasopressin and which helped in decreasing the fluid absorption. So, what is important to us finally? Good things always take time. So, safety is a priority and a skill a must. So, for safety, proper selection of the patient, having the right equipment, having a right team is extremely essential to prevent fluid absorption. And there should be a plan in place. I always say that plan the surgery in the mind and execute in the OR. It cannot be planned in the OR and executed in the OR. Then we can prevent complication. And now, since I don't have the slide to show, but there is a BSG-AG guideline for fluid management and recommendation, wherein every 10 minutes, the fluid input output is calculated and the fluid balance is written on a chart. And every 30 minutes, you review it properly and therefore reconsider at 50 minutes whether you want to go on with the procedure or stop the procedure. If there is with hypotonic solution, you are reaching 1000 ml, stop the procedure. With normal saline, after 1500, be careful that you have to finish the procedure fast. If you follow these guidelines and use minimum pressure, adequate enough to see, I think so, we should be able to prevent complications like fluid absorption. Once again, I would like to thank you. And we run a school of hysteroscopy at Symbiosis where we have courses round the year every 3 months, which are handhold courses, and we all teach the nitty-gritty and the tips and tricks how to prevent complications. Once again, thank you, Sunita Madam, for inviting me. But I'm extremely sorry if the presentation could not be uploaded.
It was excellent, sir.
Yeah.
Excellent.
Yeah.
So I think there could not have been much, better session than this. So exhaustively, Dr. Milind has covered this, and we are open to any questions and Dr. Sharda Jain's comments also.
Yeah.
I also told you that I'm no expert, but I sit down on the other side and I'm definitely scared of hysteroscopic deaths. And I think, the teachers have to see to it, the doctors are well trained before they touch the instrument.
Yeah, ma'am, there are many myths in hysteroscopy, that hysteroscopy is a very simple procedure, but I'll tell you, it's a tricky procedure. You cannot see one and do one. You have to be trained properly into all the instrumentations, and you should know your fluids very well. You should know your instruments very well, which was covered by Renu Mishra ma'am. And this is very important. This basic thing is very important before you go, because myomectomy, endometrial resection, are most advanced form of hysteroscopic. And now, if you go internationally, ma'am, I have the opportunity to go internationally. They say this is not, you're not gynecologist. When you do this myomectomies, you're known as intrauterine surgeons. So when you're intrauterine surgeons, you should be very careful with that sacred cavity, the endometrial cavity, and we should see that we don't damage the cavity and create complications. Patient walks in and should not go on a stretcher into an ICU. I just don't like it. I get many phone calls every day but people have to know their fluid balances very well, should know which solution they're using, what type of surgery, and as rightly said, even by Renu madam, that you have to counsel the patient first, that this is a difficult procedure. I need to stop the procedure. You cannot tell the relatives later on, I stop the procedure. You should have already counseled the patient that I may have to stop. So it is better to counsel the patient and do a procedure with entire team than to put your foot into it and land up into a complication.
Dr. Milind, you are the first one, I've met who have accepted that you get the calls almost every day when the patients have problem.
Yeah,
It is
yeah,
underreported mortality as far the hysteroscopy is concerned.
yeah, absolutely, ma'am. Absolutely.
Dr.
Thank
Renu
you.
ma'am, your comments, Dr. Sharma sir.
I think it was very exhaustive and very well covered.
Yeah.
So, but eventually we still need to stick to our basics
Yeah.
and follow, because the one big, like I said, everybody thinks it's very easy, but the problem with hysteroscopy vis-a-vis laparoscopy is that in laparoscopy, when you put, you will see some landmarks. कहीं uterus दिखेगी, कहीं bowel दिखेगा, कहीं omentum, कुछ तो पता चलेगा कहाँ है. In hysteroscopy, I've seen people in the cervical canal and saying, देखो कितने adhesion है. Because there are no landmarks. So there is no shortcut to training. And
Yeah.
it is not a very long training that you require, but there is no shortcut to training.
Yeah.
I think if we know our fluid management in detail and in depth, if our concepts are clear, then the kind of confidence we get while doing the procedures, it is unparalleled. It is class apart. If we are a good surgeon and we know these basics also, so that's very
Madam,
important.
can I add something to this? We should, I don't know, maybe those who are in the organization or who are in teaching line in big institutes should see that hysteroscopy should be a part. Laparoscopy may or may not be. Hysteroscopy is your stethoscope. As rightly said by AGL, hysteroscope, my stethoscope for a gynecologist. So what I believe is it should be included in your training program when a person takes as a JR, he joins. They should be taught when they come out. They should know basic hysteroscopy fully well. But it is not included in many colleges. Many JRs, when they come out, or SRs they come out, they have no idea about hysteroscopy. They have seen few, but never done, and that is not good. If I was trained in Italy, ma'am, I'll just tell you, in the last year of training, 6 months they had to do hysteroscopy and laparoscopy compulsory before they even appeared for the exam. So something of this sort has to be inculcated in our training program so that the youngsters of the new generation learn it properly and are safe.
Right.
Yeah.
So I think Dr. Sharma sir is there, so we can take his comments and then after that we can conclude. Dr. Sharma sir.
Yeah, thank you, Dr. Telang. It was a beautiful lecture, and one revisited the what we learned at the beginning of our career, and you refreshed whatever there were little cobwebs. Also, you moved that. Yes, it is very important in a hysteroscopy to understand not only the equipment, also the fluid and the physiology, the mechanism, and another thing is whenever you are doing a hysteroscopy, there should be another person who is doing the fluid management. Instead of, because you get so involved in the surgery, you forget how many bottles have gone in and how many how much liters of fluid have come out. So there should be a dedicated person doing only this job, nothing else. One sister giving you the equipment, dedicated, who understand all the equipments, and another person who just to calculate how many bottles have saline have been used or glycine has been used and how much it has come out. If you keep these things two in mind, you will never have a problem.
And if I can just add one more line, that you should have no water on the floor. There's no question of mopping and weighing the drapes. And you don't need to have fancy drapes. They cost. Patient has to pay for everything in a private hospital. What we do is we just put a simple plastic drape going into the bucket. The bucket is empty. There's nothing. And only the fluid, when you're passing the hysteroscope, goes into the bucket. That also is very limited. If you keep the suction on, there is nothing on the floor.
That's very important. Collect the complete fluid.
Absolutely.
Yeah.
Ma'am, can we wind up and call it a day?
Please.
So thank you so much, Dr. Milind, Dr. Renu, and Dr. Sharda Jain, ma'am, for such enlightening talks. I